Okay, so today we'll be talking about CT parameters and radiation and what radiologists need to know about these. So what does the term exposure mean when applied to radiation, and how do we measure it? Well, the term exposure, we can think of it as the number of X-ray photons passing through a given area. So this is determined or measured by the ability of the X-rays to ionize air, and this is measured in an ionization chamber using an electrometer. It's measured in Röntgens, and one Röntgen is the quantity of X-rays that produces this particular number of coulombs of kilogram per kilogram of air. And so this is named after Wilhelm Röntgen, who's a German physicist, as we all know, who discovered X-rays, and he was the first he received the first Nobel Prize in Physics in 1901. And even back in his time, he routinely used protective lead shields. Well, the SI unit is the air kerma, or kerma, and this is a measure of X-ray intensity, and it's measured in joules per kilogram of air. And so this is we would call this unit then a gray, and this is the absorbed dose within air. So the term kerma stands for kinetic energy released per unit mass. So 1 gray is 1 joule per kilogram of air. So it's this amount of energy, 1 joule per kilogram of air. So we need to also know the differences between these terms: absorbed radiation dose, dose equivalent, effective dose. What are the units and how are they different? The term absorbed radiation dose is the amount of energy absorbed per unit mass at a specific point. So this is measured, the unit here is grays, and 1 gray is equivalent to 1 joule per kilogram of a particular mass. This is named after Lewis Harold Gray, who was a British physicist who studied the effects of radiation on biological systems. He's thought of as the father of radiobiology. Now, when it comes to biological tissues, there is biological damage produced by radiation, and the dose equivalent is the unit for measuring that. So this is a measure of biological damage to living tissue from radiation exposure, and this is measured in sieverts, named after Rolf Maximilian Sievert, who was a Swedish medical physicist, and he developed instruments for measuring radiation. He studied the biological effects of repeated exposure to low doses of radiation, and he was a strong advocate for radiation protection. And he was the chairman of the International Committee for Radiation Protection during those years. So again, the dose equivalent is a measure of biological damage to living tissue from radiation, and this is measured in sieverts, and it is the absorbed dose times this quality factor, and this quality factor depends on the type of radiation, because certain types of radiation are more damaging to biological tissues than other types. For X-rays, that quality factor equals 1. For alpha rays, which are more damaging, it's 20, and for neutrons, it's between 5 and 20. Now, the effective dose is the weighted average of those equivalent doses to all organs, accounting for varying radiosensitivities of the organs. And you can see the weighting factors that are listed here and the organs listed here. And it turns out, as you can see, that the weighting factor for being exposed to the same amount of radiation for the bone marrow is higher than it is for the brain. So the brain is not as radiosensitive as the bone marrow. And so if you expose both of these to the same amount of radiation, the amount of biological damage will be greater in the bone marrow than it would be to the brain. So there has to be a way of accounting for that. And this is accounted for using effective dose, where we apply this weighting depending on the radiosensitivities of the particular organs that are exposed to the radiation. So the effective dose is the uniform whole body dose that results in the same stochastic risk, or the same detriment, or the same radiation risk as the absorbed dose from any given non-uniform exposure. So this is a way of converting exposures for various radiological procedures using this standard weighting system so that we can compare the biological effects, or we can compare the risks of different types of radiological procedures depending on or taking account the radiosensitivities of the particular organs that are exposed. So if we look at the effective dose here in millisieverts, we can see that it's quite small. For a chest x-ray, it's about 0.1 millisievert compared to the background radiation that people are exposed to throughout their lives, which is about 3 millisieverts per year. A chest CT is about 8 millisieverts, and an abdomen pelvis CT is about 10 millisieverts. So general rule of thumb is that a CT abdomen pelvis is about equivalent to 100 chest x-rays. Now, for CT, this effective dose is a calculated quantity. It cannot be directly measured because many assumptions are made when we try to estimate the effective doses for CT for various patients. It assumes an idealized reference patient model. So the doses that you see that are estimated assume a 70 kilogram hermaphrodite of average size of an average of all ages. So it's best used to assess risk for a population in epidemiologic terms, or if you're evaluating various protocols to see what their effect is in terms of changing parameters in protocols on radiation dose. This can be misleading if you're using it to predict risk for an individual patient. So calculating the effective dose for an individual patient is very difficult, and that actually requires the input of a physicist. So when we discuss these effective doses for CT, we want to think in terms of risk of the exam versus the risk to the particular patient. So what we're really doing is we're evaluating changes in parameters of protocols and estimating this effective dose, and we would use that to see how these changes in the protocols would affect the radiation doses in general that are delivered to our patient population. And so for our CT scans, we get a CT dose report. So here's a dose report from a PE protocol. And here we have on this PE protocol, we see that there are three separate series here that are indicated. The first one is the Scout. The second one is the bolus tracking here that was done to initiate the scan when the contrast is in the pulmonary arteries. And then the third one is the actual CT scan of the chest itself, which was again done for pulmonary embolism. So let's go through this, and what do each of these mean, or what do these abbreviations mean here in your dose report? So the Ctdi vol, this number here, so that is a measure of the radiation output directed at a given patient. So it's determined by the CT parameters for a particular scanning protocol, those parameters being the KB, the MAS, and the pitch. We can think of this as the average radiation output per slice of the CT scan. So this particular number, that CT dose index, will be the same whether it's one slice or 100 slices. So that's why it's best to think of this as the average per slice, especially since we're usually doing many slices and not just one. So the units of measurement for the Ctdi vol is joules per kilogram. Now, this does not tell you the total amount of energy the total amount of radiation the patient was exposed to, since this number is going to be the same whether you've only scanned one slice or 100 slices, and it's also independent of patient size and scan length. This will be displayed before the scan begins, and so the dose check, if you set this up properly, will alert the technologist in your specific protocols if the scan parameters for that protocol exceeds a particular limit you have set for that protocol. So next to the Ctdi eval here, we have the DLP, which is the dose length product. And so the dose length product here is the Ctdi eval, which is in the units of milligray, times the scan length, which is in units of centimeters. So the units for the DLP will be milligray-centimeter. Now this does reflect the total amount of radiation directed at the patient because this takes into account the dose per slice here, and we're multiplying that by the entire length that was scanned for the particular for that particular protocol or for that particular patient. So this accounts for the total extent of the scan. So DLP is the Ctdi eval times the scan length, and my rule number one here is trust no one. If you actually do the math here, you find out that there is a little bit of something that is off. So if the DLP is Ctdi eval times the scan length, and we go over here and we look at our units here, the Ctdi eval in this case, which is 20.72 times the scan length. In this case, these are in units of millimeters, and if we subtract here, we will get the scan length in millimeters, and we can convert that to centimeters, and we get 32.5. And that total is this number, 673.4, which is less than the number that's indicated here in our dose report. So what explains that discrepancy? Well, what explains that discrepancy if we're doing a helical CT scan is that the irradiated scan length is actually greater than what is depicted on our images. It's greater than the image scan length. Since we need 360 degrees of data to reconstruct a slice, this requires then some extra radiation here at the top and at the bottom, which are these will be tissues that are radiated but are not actually included in the image data that we look at. So there is extra radiation here, and this is called overranging, and this is reported in your CT dose report. So this becomes important if you have radiosensitive organs at the edges of the scan length. So if you're doing a CT of the head, we have the eyes over here, and you would want to avoid irradiating the eyes. So if you're doing a helical scan here, the eyes would get irradiated here on the bottom of the scan, even though they're not going to be included in the images that are depicted. So for head CT, an axial mode would be preferred over a helical mode. If you're scanning axially, then you would avoid this problem of overranging, and you would avoid the extra radiation to the eyes that you would get with the helical protocol. Especially important in pediatric cases here, where because of the size of the patient, the actual imaged anatomy is quite small, and then there that percentage of overranging becomes much higher compared to the anatomy that you are actually imaging. So in pediatric cases also, overranging can be a problem, and you might prefer axial to helical protocols for that reason. Okay, so getting back to DLP, so the units for DLP are milligray/centimeter. This reflects the total amount of radiation directed at the patient, and it accounts for the total extent of the scan. So now, how do we convert this to effective dose? How do we get an idea of what the actual dose is for particular patients based on the protocols that we are selecting? As we've said, measuring the effective dose in a particular patient is actually very difficult to do, and so what we're doing here is just getting an estimate of what these doses might be to our general population. So if we multiply the DLP by this multiplying factor called K, which varies depending on the part of the body that you're scanning, it does give you some indication of what these doses might be in your various protocols. So for chest CT, K equals 0.02 millisieverts over milligrade per centimeter, and that's assuming an average size adult patient, and it assumes we're scanning at 120 kV. So K can change depending on the age of the patient, the body part scan, and it can also change depending on the kV that you are using within your particular protocol. So here, if we go through the math in this particular patient and assume our DLP is about 750 for this chest CT scan, using this estimate of K, we get this estimate for an effective dose for this particular protocol of about 15 millisieverts. So as we've said, the effective dose here is the DLP times this K factor, and that K factor can change depending on the anatomy you're scanning. So here I've included K factors for different parts of the anatomy, the chest, the abdomen, the pelvis, and also for the whole body. And it can also change depending on the age of the patient. So where we have children that are going to be more radiosensitive than adults, then that relative K factor here compared to adults is going to be much higher for chest CT and also for abdomen and pelvis CT. So that's an indication that telling you that these doses and the protocols to these younger patients we have to be very careful about. And again, what we're doing here is we're looking at our various protocols and estimating what these doses would be to our general population, and looking at how they would change depending on the age of our patients. So we want to use this to assess the radiation dose of the protocol, not to assess the dose in any individual patient. Now, when we compare our dose report for a head CT, and so we have the Ctdi vol here for a chest CT over here of about 21, and the DLP is about 752. When we compare that to our dose report for a head CT, we see that the Ctdi vol here is about 67 and the DLP is 1,123. So why is the Ctdi vol and the DLP so much higher for the head CT? Is there something wrong with the head CT protocol? Well, here it's important to look at this last column, and this last column indicates the reference phantom that has been used to calculate the numbers, the standards of phantoms that are used to calculate these numbers that are used within the dose report. And the particular phantom that is used for body CTs is a body phantom that's about 32 centimeters in diameter, and for head CT it is the head phantom, which is 16 centimeters in diameter. Now, when we look at dose gradients for an X-ray from a stationary source, we see that the front of the object receives a higher dose than the back of the object as the radiation beam is attenuated as it goes through the object. Things are different though for a CT scan, where the dose is administered as the X-ray tube travels around the patient. So it is the outer portion of the irradiated objects that receives the higher dose, and as you go towards the center, that dose decreases because of the attenuation of the X-rays through the patient. So for measuring these CT parameters in terms of for dose, a 32 centimeter and a 16 centimeter acrylic phantoms are used, along with an ionization chamber, to measure the Ctdi vol within the center of the phantom. So your protocol is set, your body phantom is here, your ionization chamber is put in the middle of that, and as you would expect, there's going to be more attenuation of the X-ray beam here by the body phantom than there is going to be by the head phantom. So the Ctdi vols then for the head phantom are going to be much higher than the Ctdi vol for the body phantom. So when we take these dose measurements, comparing them for the 16 centimeter head phantom versus the larger body phantom, you will see that the doses here within the head phantom are going to be much higher than the doses here for the body phantom. Just because for the larger phantom, more of the X-rays are attenuated, so the dose to the center is going to be reduced. So therefore, when we look at our DLP for the chest CT and compare that with the DLP for the head CT, the DLP for the head CT will be much higher. But when we go to estimate the doses, the K factors take that into account. Remember, we multiply the DLP times the K factor, and the K factor for head CT is much, much smaller than that K factor is for a chest CT. And when we go through the calculation, we see that the dose, our estimated dose from this chest CT is about 15 millisieverts, whereas the estimated dose here for the head CT is only 2.7 millisieverts. So that K factor is adjusted both for the phantom size and the body part. So the K factor for the head CT will be smaller, taking into account the size of the phantom, but also taking into account that the radiosensitivity of the organs within the head are going to be less than the radiosensitivity of the organs within the chest. Now, what if we have two patients here? We have one patient who is very thin, weighs 150 pounds, and we have a patient who is very large, weighs 300 pounds. If we use the exact same CT parameters to scan both patients, our field of view is the same here for both patients. So the same CT parameters here are used so that the Ctdi vol and the DLPs are exactly the same. We've used the exact same protocols to scan both patients. Is the radiation dose the same for both patients? Is there a way to estimate the difference in the radiation dose for these patients? Well, we need to remember that the Ctdi vol displayed on the dose report is the radiation dose delivered to the 32 centimeter phantom using the selected CT parameters. It is not the dose delivered to the patient. If we look at these two patients and we've delivered the same amount of radiation to both, you can't imagine that in the larger patient that radiation will be more attenuated when it reaches the center than it would be in the thinner patient. So in some sense, the amount of energy that is being deposited here per kilogram for the larger patient should be less than that for the thinner patient. So is there a way to take that into account? And that can be done using size-specific dose estimates, the SSDE. And here what we do is we have this parameter called this F subscript size, and we can multiply that, take the Ctdi vol and multiply it by this factor, which changes depending on the size of the patient, to estimate then how the size of the patient affects the actual absorbed dose that the patient is receiving. So this F size parameter is determined by the effective diameter of the patient, and the effective diameter is just the square root of the AP diameter times the lateral diameter for the particular patient. And then there is this formula telling you what this F size factor is. I don't think it's important for you to memorize that particular formula. There is a lookup table here once that is available, and once you have calculated the effective diameter for the particular patient, then you can look up this conversion factor here, which correlates with the effective diameter, which you can then use to estimate how this is affecting the radiation dose. And as you can see, as the effective diameter here is increasing, that conversion factor is decreasing, telling you that as the patient is getting larger, the actual dose that the patient is actually receiving is decreasing. And so this SSDE here estimates the peak dose at the center of the scan in milligram. So if we go through these calculations here, in the thin patient with an effective diameter of about 29 centimeters compared to our larger patient with an effective diameter of 42 centimeters, we look up the the F size parameter here, and we see then that the actual dose, if we're estimating what these actual doses are here, that for the larger patients, the dose here is considerably lower than the dose for the thinner patients. So this is something that you might want to take into account in your protocols, that the larger patients, if you're using the same scanning parameters, the doses will be decreased, or probably more importantly, in your thinner patients, using the same scanning parameters that you might use in larger patients, the doses are actually, the doses that the patients are receiving are actually increased. So again, the Ctdi vol and the DLP that we see in our dose reports are measures of scanner radiation output. The SSDE provides an approximation of dose absorbed by the individual patient, and that will change depending on the size of the patient. So the SSDE is independent of the scan range, unlike the DLP here. So the SSDE cannot be used to calculate the effective dose in millisieverts. Remember that calculating the effective dose can be very difficult. This does not correct for patient age or differences in organ dose distribution for patients of different size. So it's best to use, it's best used to correct the Ctdi vol for patient size in a given protocol. So again, this is best thought of to see how these different protocols affect the doses that the general population might receive, depending on the particular size of the patients that you're thinking about here. All right, so let's move on to CT technical parameters. So these are all parameters that we need to be familiar with, and we need to know how these affect the radiation dose. So the X-ray tube current itself is measured in MA. The X-ray tube rotation time is measured in seconds. And so the product of that gives you the X-ray tube current time product, which is the MAS. There's the X-ray tube voltage measured in kV. There's the pitch, and we have also the reconstructed slice thickness. So the MA is the tube current that can vary during the CT scan itself, and the dose will be directly proportional to the MA. So you can think of the MA as the number of photons. So as we are increasing the tube current here, as we're increasing the number of electrons that are flying across and hitting the target, we increase the number of photons, and you can think of that as a direct relationship. The MAS is the tube current time product, so it's a measure of the number of photons here times the rotation time, so the dose will be directly proportional to the MAS. If your tube current is a certain number and your rotation time is 1 second, then your MAS then, so let's say your tube current is 300 and milliamps, and your rotation time is 1 second, then your MAS is 300. But if your rotation time is less, if it's half a second, then your MAS will be 150, which means that with the same tube current, shorter rotation times will deliver a smaller dose. So that's why we use the product here, the MAS, as the part that is important, and that turns out to be directly proportional to the dose in your particular protocols. Now the kV is the beam energy for the X-ray beam, and it's actually the peak energy, so it should be kVp, the peak energy. And on a CT scanner, these have to be preset, and you only have certain numbers to choose from, and these are the numbers that are usually available to you, kVp of 80, 100, 120, or 140 for a CT scan. And these usually remain constant throughout the CT scan, unless you're doing dual energy CT, where on particular models that can change with dual energy, but usually these are kept constant throughout the CT scan. And here the relationship to dose is more complicated, so you can think of it as a square function. So the dose is proportional to the kV squared. So you can think of the kV as the energy of the photon. So as we increase the as we increase the kV here, as we increase that kilovoltage peak here, then these electrons are hitting the target with more force, and so that results in many more photons here. But compared to MAS, which is a linear relationship, this is more of an exponential relationship. The pitch is the table distance that is traveled in one 360-degree gantry rotation divided by the total width of the X-ray beam. So again, you have this formula of the table feed divided by the beam width. So what does this mean? So if we have a 16 slice CT scanner where each slice is 0.625 millimeters, then we have a 1 centimeter slab that is scanned, 1 centimeters of tissue scanned every time the gantry goes around. If there is no overlap between those slabs, then your pitch is 1. If there is overlap between the slabs as the CT goes around, your pitch is less than 1. And if right here, as you see, if there's some spacing between the overlaps, then your pitch is greater than 1. Now a 64 slice scanner gives you more coverage with every rotation, so that gives you a 4 centimeter slab of tissue that is scanned every time the gantry goes around. Again, if there's overlap between those 4 centimeter slabs, then your pitch will be less than 1. And if those 4 centimeter slabs are contiguous, your pitch will be 1. And if there's spacing, a little bit of spacing, as you see here, then your pitch will be greater than 1. So you can have a low pitch scan where you have some overlapping between the different slabs, or you can have a high pitch scan where you decrease, where you can have very little no overlapping actually between the scans, and some spacing actually between those slabs. So the dose here will be related inversely to the pitch, assuming that all other factors are unchanged. But there is one caveat: if you're using automatic exposure control, which we will discuss in a little bit, increasing the pitch does not usually decrease the dose, because your automatic exposure control will take into account the fact that you have increased the pitch in the protocol and will adjust usually the MA to maintain a constant dose. Now, what are the advantages in your protocols and disadvantages of increasing the pitch? Well, if you have a high pitch scan, you can scan the anatomy much faster because it takes less revolutions of the gantry to get through the particular anatomy that you're scanning. The one disadvantage to that, though, is that you might get distortion along your z-axis because you have some spacing there between these slabs of tissue that are required in your separate rotations. So that is a disadvantage of using high pitch. So the advantage of high pitch is a shorter scan time. The disadvantage is you can get these possible distortions along the z-axis. The advantage to low pitch is redundant data, especially if you're doing a cardiac CT. So if you're doing a cardiac CT, helically, those are usually done with low pitch. There you get some redundant data. So if there's an irregular heartbeat, you might have enough data there to overcome that irregular heartbeat. But the lower pitch here, again, assuming everything else stays the same and not accounting for automatic exposure control, the higher pitch will give you lower dose than the lower pitch scan. Now, with Siemens, they use something called an effective MAS, and this effective MAS is this effective tube current time product, which is this MAS effective equals the MAS of your protocol divided by the pitch. And so what the user selects is not the MAS, but the effective MAS for a particular protocol. So if the pitch is changed in your protocol, the MA is adjusted to keep the effective MAS constant to maintain the image quality. So with Siemens, changing the pitch then does not really change the dose, as the system adjusts to keep this MAS effective constant throughout the particular scan. So as opposed to a GE scanner where if you change the pitch, nothing else necessarily has to change, and so changing the pitch or increasing the pitch may decrease the dose, but that is not necessarily true on a Siemens scanner. Okay, assuming you have a 16-slice CT scanner, so each slice is 0.625 millimeters, and we compare that to a 64-slice scanner. So if the pitch is 1 and all other parameters are identical for both scanners, for a CT scan of the chest in a given adult patient, which of the following is true? In essence, what we're saying is, if we scan the CT of the chest with a 16-slice scanner or a 64-slice scanner and change nothing, which would give the patient, is there a difference in the dose between these two types of systems? Would the 64-slice scanner give a higher dose, or would it give a lower dose? The actual answer is the 64-slice scanner would give a lower dose, and the reason for that is this thing that we call the penumbra, because each time there's a rotation of the gantry, there is some radiation that is wasted here at the edges of the beam. So this wasted radiation goes into the patient, but is not actually detected by the detectors and does not go into making up the image. So every time there's a rotation of the gantry, more radiation is wasted. So if there are less rotations of the gantry, then there's less wasted radiation. Now a 16-slice scanner only covers a 1 centimeter slab of tissue every time the scanner goes around, as opposed to a 64-slice scanner, which covers 4 centimeters of tissue every time the scanner goes around. So what that means is, for scanning a CT of the chest, for scanning a particular length of anatomy, the 16-slice scanner will require approximately 4 times the number of rotations as a 64-slice scanner requires, and so therefore you get more wasted radiation because of the penumbra, and so that wasted radiation then goes into the patient, and the radiation dose to the patient then is increased. So the 64-slice scanner is more dose efficient than the 16-slice scanner. Now, what about reconstructed slice thickness? Well, that does not directly affect dose, because that can be done after the CT scan is finished, after the patient has left the department. There's an acquired slice thickness which determines the minimum slice thickness, and these are usually nowadays about 0.625 millimeters. So on a 64-slice scanner, your slice thickness is about 0.625 millimeters, and that approaches the resolution then in terms of the slice thickness along the z-axis as the resolution that you have in the xy axis. So when you reconstruct these voxels, these voxels have the same resolution then in all dimensions, and so that is called isotropic imaging. As opposed to this example here, if we were to reconstruct here, instead of 64 slices at 0.625 millimeters, if we were to reconstruct that same volume as 32 slices at 1.25 millimeters, now you can see how the dimension along the z-axis has changed. So now these are no longer isotropic voxels here. And so that becomes important when you are reconstructing images in different planes. When you have isotropic voxels, you can do coronal and sagittal reconstructions without any loss of resolution. If you don't have isotropic voxels, even though the images, your axial images look pretty good, when you go to reconstruct your images in sagittal and coronal planes, you might get that kind of blockiness that we can see, especially if you try to reconstruct thick sections in axial or coronal planes. In practice, 1.25 millimeters is usually good enough, but if you try to reconstruct, let's say, 5 millimeter slices in axial and sagittal planes, then you can really appreciate the blockiness there and the fact that the resolution is nowhere near as good as what you're looking at in the axial plane. Now, assuming that all other parameters are kept constant, which of the following results in the greatest dose reduction? So if reduce MA from 400 to 300, if reduce the pitch from 1 to 0.5, if reduce the KV from 120 to 100, or if reduce the reconstructed slice thickness from 5 millimeters to 1.25. Well, from what we've just discussed, you know that changing the slice thickness, that reconstructed slice thickness, is really post-processing, so it would not affect much at all. We know that changing the MA affects the dose linearly, so going from 400 to 300 there gives you a 25% dose reduction. Decreasing the pitch is not a good idea if you're keeping everything else the same. Remember, decreasing the pitch actually increases the dose. So if you decrease the pitch from 1 to 0.5, you get a 100% dose increase. Now, changing KV gets interesting. If we change the KV from 120 to 100, remember that the dose is related to the KV squared. And so we go through those calculations here. We square these numbers, and we see here that at a dose of 100, the dose is 69% of what it is at 120 kV. So that's a 31% dose reduction. So decreasing your kV is a very efficient way of reducing dose. As we've said, changing the reconstructive slice thickness does not really change the dose. Okay, now we talk about quality of CT images. So what can we use to objectively measure the quality of a CT image? You look at these two images and you can say, gee, this image looks a lot better than that image. Well, what is it that we see that makes this image look better? And is there a way to quantify that? So we call this noise. So this noise, this image looks more granular than this image. So this image is noisier than this image. So these noisier images look grainy. So the noise within an image is a good measure of the image quality. So how can we measure that? So the noise is random variation of the Hounsfield units that are imposed on the image. And we can measure that by looking at the standard deviation values of the Hounsfield units in a region that should be homogeneous. So that is a measure of the amount of noise within an image. And this is measured using a water phantom, ideally when they're calibrating CT scans. So here, what we can do is we can take this bit of muscle over here where the attenuation should be relatively homogeneous. And what is the standard deviation in there? Well, on our noisy image, it comes out to 48. On our image that is less noisy, it comes out to 19. So the standard deviation is a good measure of the noisiness of an image. Now, what is the relationship of image noise to radiation dose? Well, the image noise is determined by the number of photons that produce the image. Generally, the more photons that you use to produce the image, the less noise there will be. So more photons means higher signal to noise. More photons means less noise. Less photons means more noise. And so that relationship then, the image noise is proportional to 1 over the square root of dose. So it's an inverse relationship, and you can understand that as you are increasing the dose here, you will be decreasing the amount of noise within your image. And that's the trade-off that you have to make for protocols where you try to decrease the dose. As we decrease the dose, we will be increasing the image noise. Now, what about slice thickness or reconstructed slice thickness? So these are images taken from the same CT protocol or the same scan in a particular patient. We've just changed our reconstructed slice thickness. So here our reconstructed slice thickness, very thin, 1.25. Here it's 5 millimeters. Which image has more noise? Well, when we look, this image looks much grainier than this image. So The thin cut here is noisier than our thick cut. And what is that relationship? Remember, this is the same study, just reconstructed at different slice thickness. So that relationship, noise, is proportional to 1 over the square root of slice thickness. And if we actually measure the standard deviation here to show you, so here on our thin cut, the standard deviation here is 20, and here on our thicker cut, the standard deviation is 10. Remember, we said that the noise is proportional to 1 over the square root of the slice thickness. So here, where this slice is 4 times the thickness of this slice, the noise here would be about half of the noise in the thinner slice, and that's exactly what we get here. Now, is there a way to maintain constant image quality throughout an entire body CT scan, given the differences in the thickness and attenuation of the body in the scan range and differences between patients? So here, if we're scanning this chest, you're scanning through these areas up here where there's more soft tissue, and then you come down here where there's relatively more lung, and you get up here to the upper abdomen, and there is more liver here. Well, is there a way to adjust the scan as it is going on so you are not over radiating these parts, which will not require as much radiation to give you diagnostic images, as opposed and under radiating these parts where the soft tissues are much thicker, and so then you might get non-diagnostic image quality. So given that large changes then in the types of tissues that we're scanning, how can we adjust the CT scan itself as it is going on to take that into account? And this is done through tube current modulation or automatic exposure control. So what this does is it increases the MA for the thicker body parts or for larger patients. So here, when you're scanning through the liver, you want more MA, so that gives you less noise and better image quality. Here, we're scanning through the lungs, you don't have near as much soft tissue, so here you can have diagnostic image quality with less MA. So here you'd want to reduce the MA for your thinner body parts and also for smaller patients. So this allows you to maintain constant image quality without excessive radiation to thin body parts. So we can set a minimum MA in our protocols, that MA min, and we can set a maximum MA. So this way we can make sure that the MA does not go below a certain threshold so that our images are not too noisy, and we can make sure that our MA does not exceed a threshold so that we are not delivering too much dose for our patients. And this is done through automatic exposure control. And the way this works is that as the X-ray tube is going around the patient and going through the various body parts, the MA is modulated in this XY plane and along the G axis. G calls this process smart MA, so that when the X-ray tube, let's say when we're scanning from here to here, from top to bottom, let us say, we decrease the MA since we're not going through a large amount of thick soft tissue. But when we're going here through the side, where we're going through a thicker amount of soft tissue, here we would want to increase the MA. And so we do the same thing when we get to the abdomen. So there we would change the MA along the Z-axis because the tissues are much thicker. So this adjustment of the MA on the fly as we are scanning through the patient is what helps us to maintain our image quality during the scan. And so you can see here what's happening to the MA here when we're close to the shoulders and the soft tissues. The MA is high. As we're going through the lungs here and we're going through a less amount of soft tissue, it drops. And then here, when we get to the abdomen, it goes up again as we're scanning through the liver. Now, there are more advanced techniques that can be organ specific to reduce the radiation dose of breast tissue. So when you're scanning from the anterior direction, that might decrease the amount of radiation you're giving to the breast tissue. So this has also been attempted. So we have longitudinal tube current modulation, where we change the tube current depending on the thickness of the anatomy that we're scanning here from the top down. So here, of course, the abdomen organs, because the organs here in the abdomen, much thicker, soft tissues. So there we would want to increase the MA. And then we also have here longitudinal and angular tube current modulation. And so here what we're doing is we're not only changing the MA along the z-axis, but also for every slice as the scanner is going around the patient. As we've said, when you're scanning from the sides where the tissue is thicker, you would use a higher MA to be able to get diagnostic, to improve your diagnostic image quality. So when we're using this tube current modulation, your Ctdi vol displayed is the average Ctdi vol over the length of the scan. Now, what we do on G types of scanners when we're trying to adjust image quality for the particular protocols is we select this parameter, which is called the noise index, and that sets a maximum noise level for our protocol. So think of the noise index as a standard deviation of Hounsfield units in a homogeneous region. So in this particular image, I've set for this particular scan, these are two separate CT scans. In this particular scan, the noise index was set to 10. So when we look at the standard deviation here of the fluid within the bladder, it's about that. It's about 11 is the standard deviation. Here where the noise index was set to 15, so it was set to a higher value, you would expect more noise in this image. Here the standard deviation is a little bit above 15, almost 16, as you would expect. So what happens is for your particular protocols, your preset protocols, you select the noise index depending on what parts of the body that you're looking at and how much what your desire is in terms of image quality, realizing that there is this trade-off that as you decrease the noise index to improve your image quality, you are increasing the dose within that particular protocol. So using this tube current modulation, the tube current modulation then will change depending on the amount of tube current modulation, or the extent of it changes depending on the noise index. So you can see here that when the noise index is set higher, meaning that you are tolerating or you're going to tolerate more noise in your images, you can see that this tube current modulation, the amount of tube current here is not changing as much as it is here where we set a lower noise index, and here we get really high values, close to 650 here when we're going through the abdomen in this particular patient. So the lower noise index then does result in higher MAs and higher dose to the patient. So if your noise index is set for the particular thickness of the slices that you want to look at in your images. So you have to be careful about the thickness of the slices or the diagnostic quality that you want, given the thickness of the slice that you want to be evaluating. So if you erroneously set a noise index of 10, for a 1.25 millimeter slice, you would increase the dose 4 times. So here is a 5 millimeter slice, and the noise index is set to 10 for this 5 millimeter slice. And in your protocols, your noise index is set according to the slice thickness that you want diagnostic image quality in. You would select that. So here, if we select 10 for a 5 millimeter slice, we have pretty good image quality. But if you erroneously set that, or if you choose to set a noise index of 10 for a 1.25 millimeter slice, meaning that for these thin slices, you want to have decreased noise. You want to have image quality of these thin slices approaching the image quality you have in this 5mm slice. What happens is you will be increasing the dose 4 times. So be very careful when you're changing the noise index to make sure that you are adjusting it for the particular slice thicknesses in your protocol that you want to reconstruct. And at constant noise, the dose, as we've said, is proportional to 1 over the slice thickness. So if you want the same noise within these 2 particular slices, you will be increasing the dose 4 times. Now, noise tolerance and body habitus. In thin patients, because you don't have a lot of intra-abdominal fat to apply contrast at the edges of organs, we don't have very good tolerance for noise. So we need low noise in thin patients. However, in patients who have more fat, more intra-abdominal fat, you can tolerate higher noise in fat patients. So fat is your friend. And if we compare these two images here, you can see how if you have more intra-abdominal fat, you can see the edges of the organs much easier, as opposed to these thin patients where it is a little bit more difficult to get that to see the edges of the organs better. So with the GE scanners, you would select the noise index for a protocol, and the automatic exposure control will try to maintain that noise index regardless of the patient's size. So if you have a larger patient as opposed to a smaller patient, remember, the larger patient, the scans might be noisier. So on a G scanner, it will wind up with increasing the MA to try to give you the image quality that you're desiring within these larger patients. With Siemens, they take a different approach. The MA is varied such that the scans in larger patients have more noise to reduce the amount of radiation in larger patients. So what they do is they take into account that in the larger patients, you are usually more tolerant to the noise within your images, so that the MA will not be varied as much as the MA would change on a GE scanner in the larger patients. So now, how does automatic exposure control do all these things? Well, it uses the scout image to estimate the patient's size and adjust the MA settings. So the lateral scout is usually done first to make sure that the patient is centered within the gantry. And on the G scanner, the last scout image is used for automatic exposure control, which is why it's important to do the AP scout last. So the software here estimates the oval ratio of the patient based on the brightness and width of the scout image. So using algorithms that are preset, it estimates the size of the patient and the thickness of the patient to then change the MA as you are scanning through the patient to maintain constant image quality, maintained for the different parts of the patient that you are scanning. So it's important to use the same KV for the scout image as used for the actual scan, since the calculations for this exposure control, the automatic exposure control, makes that assumption. Now, why is it important that the patient be properly centered in the CT scanner when you're using automatic exposure control? Remember, your lateral image is taken first to make sure that the patient is properly centered. Because if the patient is not centered, then when you do your AP image, let's say if the patient is centered too low, when you do that, when you take that image, if the patient is not centered properly, the image can be magnified. So here, if the patient is too low, and we've taken here actually a PA image on this projected tomogram, and what happens is that because the image is magnified, the software assumes that the patient is 40 centimeters wide when the patient may only be 36 centimeters wide. So we'll erroneously assume that the patient is larger, and so the opposite can happen if the patient is centered above the isocenter of your scanner. So this changes the size assumptions as far as the software is concerned for your particular patient, and can give you poor image quality or might result in over radiating the patient. Now, another important consideration, if you are using automatic exposure control, does the position of the patient's arms affect the radiation dose, and how large is that effect? Are the arms down or are the arms up? If you're scanning a CT chest, if the arms are down versus if you scan the same patient with the arms up, what difference does that make in terms of the radiation dose to the patient? Well, this was studied in this particular paper, and with the arms up in these patients, you can see that the estimated dose is about 18.6 millisieverts as opposed to the arms being down. Again, the CT scanner with automatic exposure control, as it's going through all of this extra soft tissue, tries to maintain the same image quality, so it will increase the MA of the scan and it will increase the dose to the patient. So with the arms down, it's 45% increased dose. So if at all possible, when you're doing CT scan of the patient, it's important to keep the arms up. It's better for image quality also. You'll see much better image quality, but also it's important for reducing the radiation dose to the patient. Now, what are techniques that we have to reduce radiation dose? We can have focused collimation, where we restrict the scan field to only the necessary anatomy to reduce, and we can also reduce the number of scan phases. Use a lower kV for thin patients. If you use 100 kV instead of 120 kV, that lower kV, we can compensate for some of the increased noise there by increasing the MA to maintain our image quality, but overall the dose will be lower with that adjustment. We can lower the MA if we don't need that much MA. We can tolerate higher noise, especially in larger patients. We can use a higher noise index if you're using a GE scanner, because you're more tolerant for more noise in the larger patients because they have more intra-abdominal fat. For cardiac gating, we would like to use prospective gating. That decreases the dose. If you're using retrospective gating, you want to use ECG modulation. And also iterative reconstruction now is another way of decreasing the dose. So focused collimation, if we're only scanning, if we're only interested in the heart here, then you decrease the scan range to make sure that only the anatomy that you're interested in is the anatomy that is scanned. So reducing the scan coverage 50% reduces your dose 50%. We can adjust the KVs in our protocols based on the patient weight or the BMI of the patient. Remember, the dose is proportional to KV squared. So for the large patients, you need a high KV, but for your smaller patients, you can do diagnostic scans at lower KVs, and that considerably reduces the dose. So in your protocols, you can set the KV depending on the body weight or BMI of the patients. Also, the lower KV improves the appearance of contrast, because the closer we are to the K edge of iodine, the brighter iodine looks. So here at 100 kV, even though the image is a little bit noisier, the iodine looks brighter. So that can make your contrast scans look better using the lower kV. For cardiac gating, if you're doing retrospective gating and you have to scan the entire cycle, you can maintain your highest dose here during diastole when you're looking at the coronary arteries, but then you would decrease the dose during systole when you're not really looking at the coronary arteries there. So systole, you would decrease the dose, and that can also considerably reduce the total dose in these patients. Whenever you can, you'd like to use prospective gating as opposed to retrospective gating. With prospective gating here, we're only imaging during diastole, as opposed to retrospective gating where you're imaging, the X-ray tube is on throughout the cardiac cycle. So this also would decrease the dose when you're doing cardiac imaging. Now, filtered back projection is the standard reconstruction algorithm that has been used in CT in the past. It's a very rapid reconstruction algorithm, but the problem is it propagates noise in the raw data, especially at lower doses. And now we have iterative reconstruction. So let's explain what this is. So what iterative reconstruction does is this is a way of actually reducing the noise in the image uh, without really increasing the radiation dose. So if we have an object, we do a CT scan, we have this raw data in the object, we apply filtered back projection, we have an initial image, and from that initial image, the software constructs a virtual object. It then takes this virtual object and models the actual physics of the CT scanner to do a virtual CT scan of this object, and it comes up with this virtual raw data. It then compares the virtual raw data to the actual raw data and then starts to modify the virtual object here to bring these two as close as it can to each other. And then once they are close enough, it then gives you this final image. So this is extremely computer intensive and was not available until recently when we had much better and faster processors. But what this does is it reduces the noise in your image, which means then that you can, if you choose to, reduce the exposure factors up front in your CT scan protocols. So by reducing the noise in your image, your radiation dose can be decreased in your protocols. So here we have an image filtered back projection at 150 MA and filtered back projection at 40 MA, and you can see that it's much noisier at 40 MA compared to 150, as you would expect. But then when we look at these images reconstructed with iterative reconstruction here, using again 40 MA and much less dose than we have here for our filtered back projection images here, and you can see that the image quality here is somewhat better than the image quality here at 40 MA. If we use this different type of model-based iterative reconstruction here at 40 MA, we actually get less image noise than we have at 150 MA using filtered back projection. So what this means is that using iterative reconstruction, because this decreases the noise in your image, you can decrease the exposure factors up front in your CT protocols to decrease the doses to your patients. So this is something that we should be using in all our CT scans to decrease the doses in our CT protocols. Okay, well, thank you for your attention, and we'll see you next time.